Learning how to read a face? This is a great place to start. Welcome to Radiology. Hi, I'm Ian Gray and welcome to Radiology. So, how do we read a CT of the face? Well, mostly it begins with no fluid, no fracture. You look for soft tissue swelling, you look for fluid places, and then you look up the structure that may or may not be broken. But we can do so much more. What we're going to do in this discussion is cover every cubic voxel of the face. It's a lot of information, and I'd recommend that you take notes or watch it a few times at double speed so you can kind of imprint a good search pattern into your head. Is this search pattern too much? Probably for most people, but everything is a yield curve. You can cut off some of these things and still pick up 95% of pathology. But if you go through this entire search pattern, you're going to pick up 99.9% of things. And really, the best part is, by looking at all these structures on every patient, you'll find that whenever something does pop up that's incredibly unusual and abnormal, you'll see it with ease. So let's begin. I'll start at the top and I'll look at the superficial soft tissues, and I go front, go down, and I'm just making a note. Oh, look, there's soft tissue thickening over the bridge of nose and left nose. Keep going down, 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 down. Then I'll look at the left face, and as I'm coming up, I see a bandage and I see a skin laceration. Then I keep coming up. Now on a face, oftentimes the back of the head is excluded, so I'm not going to assess that. Then I'll look at the right superficial soft tissues and I'll go down. So I'm rastering up and down. Okay, so I look through that and that seems fine. I'll come back up and I'll look at the skull, and again I look at the flat parts of the skull, and I'll look at the front, then the squamous temporal bone and parietal bone as much as I've got. I don't have the occipital bone, so then I'll skip over to the right parietal and squamous temporal bone, and then I'll go to the face. I'll look at the right zygomatic arch. I'll come up to the top of the orbit, and I will look at it along the top of the orbit to the right lateral orbital wall, orbital floor, medial orbital wall, back up to the top, then the left orbital roof, medial orbital wall, all the way down to the orbital floor, and I see that there's discontinuity and fracture. And then I come up the lateral orbital wall, again I see fracture, all the way back up to the roof. Then I look at the left zygomatic arch, and we've already seen that the patient has a left facial injury with lateral orbital wall and orbital floor fractures, so this is highly suspicious for a zygomatic complex fracture, and of course we do see a subtle irregularity along the zygomatic arch. Then I'll look at the nasal bridge, nasal bones, noting the fracture, coming down to the anterior maxillary spine and alveolar ridge. Then I look at the paranasal sinuses. Most fractures will be associated with at least mucosal thickening, but most often fluid. So I'm looking for fluid, and I see in the left maxillary sinus we've got fluid. And then of course I'll look a little bit closer and we can see easily that they have a fracture along the posterior lateral maxillary sinus wall and anterior maxillary sinus wall. Again, these are findings commonly seen in a zygomatic complex fracture. Then I'll look more at the posterior sinuses, including the sphenoids coming down to the pterygoid plates. And I'll look at the left pterygoid plate and right pterygoid plate. Then I'll look at the hard palate. Then I'll look at the teeth, roots, alveolar ridges of the maxilla. I'll come back up and I'll look at the left mandibular condyle, the left coronoid process, the left mandibular ramus, the mandibular body, the symphysis, right mandibular body, ramus, coronoid process, and condyle, all the way up to where it seats in the temporomandibular joint, and you can see here that they're both symmetric. Then I come back up, again following the pattern I established in the CT head. I look at the anterior skull base, left middle skull base, specifically the foramen ovale and spinosum, right middle skull base, specifically ovale and spinosum. Then I look at the right mastoid temporal bone, external auditory canal, tympanic membrane, ossicles, vestibular cochlear apparatus, internal auditory canal, then the left internal auditory canal, vestibular cochlear apparatus, ossicles, tympanic membrane, and external auditory canal. Just like within the sinuses, if there's a fracture in the temporal bone, you typically have fluid within the mastoid air cells. The fluid is often localized to where the fracture is and is often linear. And of course, I love my foramina, so after I've looked through the visible temporal bones, I'll make sure to include the carotid canal down through the horizontal and vertical Petrie segment on the left, and then the left jugular foramen, then the right jugular foramen and carotid canal. If I have it, I will look at as much of the occipital bone as I can see, down to the foramen magnum, and of course, paying attention to the craniocervical junction. Anytime you have a fracture anywhere, it increases your risk of fracture everywhere. So people with facial fractures often have cervical fractures. And I'm looking down through the spine. And then I'm pretty much done. I'll use the coronal imaging in order to answer any questions that I might have come up with on the axial imaging, but it really is great for assessing the orbits. So I'm looking at the right orbit, now I'm looking at the left orbit. You can easily see the orbital fractures, and even though this examination isn't optimized for soft tissues, you can see the inferior rectus and its relationship to the fracture. You can see the sinuses, the teeth, everything that you'd need to see. The other things that I love to look at are the occipital condyles, because occipital condyle fractures can be difficult to see on the axial imaging. And of course, the craniocervical and atlantoaxial relationship is incredibly important. I'll look at the sagittal, again, to answer any questions that I might have come up with, but most often it is helpful when assessing the mandible. So I'll pay particular attention to the condyle, the cornoid process, and the ramus on both sides. Now this gives me my preferred view to assess the visible cervical spine, so I will take a moment to make sure that there are no gross abnormalities. The lack of prevertebral edema is pretty reassuring. However, this is not a complete exam of the cervical spine. Once I've finished looking at the bones, I will resume my assessment of the soft tissues, much the way I did on the CT of the head. So I begin with the brain in this situation, though, because I want to make sure that I can check it off my list. I'll look at the 4200 window, particularly examining the subdural spaces. Then I will move to my 4080 window and look at the frontal lobes, left temporal lobe to the parietal lobe, right parietal lobe to the temporal lobe. I'll look at what I can see of the basal cisterns, interpeduncular fossa, and cerebellum, down to the foramen magnum. I'll return to my 4400 soft tissue window, and I'll look at the right globe, the intraorbital contents, noting the optic nerve and rectus muscles. I'll look at the left globe. Things I pay attention to are the thickness and symmetry of the space anterior to the lens, as well as the roundness of the globe and size of the globe as a whole. In the setting of trauma, the most common finding you'll have associated with fracture is an extraconal hemorrhage. Occasionally you'll have a little bit of air within the orbit, but the dangerous things that you can see are any form of hemorrhage behind the globe or tenting of the globe, anything that might suggest traction of the globe. Once I'm done with the globes and orbits, I'll check out the pterygopalatine fat, left and right, the retromaxillary fat, left and right, the parapharyngeal fat, left and right, the right masticator space, the left masticator space, the prevertebral and retropharyngeal spaces, the thyroid gland, the parts that I can see, the left subindibular gland, the right subindibular gland, the left parotid gland, the right parotid gland, the anterior pharynx, including the nasopharynx and oropharynx, the posterior pharynx, down to the visible larynx, the left sternocleidomastoid and nodes underneath, the right sternocleidomastoid and nodes underneath, and any muscles that I can see posteriorly. Congratulations on making it through the CT of the face. I know there are a lot of small parts to cover, but you can do it. You're a great radiologist. It all begins by looking at a lot of patients. So I just recommend you go out there, keep looking at faces, keep looking at normal variations and abnormal findings, and keep helping your patient. Thank you for watching the video, and I hope you found it helpful. If you did, please feel free to click the like button below. Also, subscribe to my channel. You can follow me at X-Ray Gray, and I look forward to seeing you out there in the world of radiology. For those of you who are watching who aren't radiologists, I am planning on creating a series for clinicians and for patients. So please feel free to let me know whatever you need, and I'll do my best to take care of it. See you next time on Gradiology.